Once again, thanks to Dr. Jyoti for a fantastic program and inviting all of us here. Dr. Samar, please. To start with this session, we have very well-known first speaker, Dr.V. Mohan, Padam Shri. He is a chairman and chief of diabetology, Dr. Mohan's Diabetes Specialty Center, Chennai. He is having multiple centers across the country. This Dr. Mohan's Diabetes Specialty Center is a WHO collaborating center for non-communicable disease prevention and control of IDF Center of Education also. He is the president and director of Madras Diabetes Research Foundation. He awarded several prizes and medals during his undergraduate and postgraduate medical study. Published over 920 papers in peer-reviewed journals, one of the highest in any Indian scientist or doctor who had published these many papers. With 593 original articles, he had published many chapters in textbook of diabetes and in internal medicine in India as well as abroad. His current research area and interest are epidemiology, complication, genomics, and prevention of diabetes through community empowerment. Over to Dr. Mohan, sir.
Thank you, Dr.Banshi and Dr. Samar Banerjee. I'd like to thank Dr.Jothydev and his team for inviting me for this very prestigious meeting and to share with you some thoughts on the GLP-1 therapies. I must apologize that immediately after this talk I have to leave because I've got a social commitment to which I had committed some time ago. So I'll be back definitely in the evening. I'm there tomorrow also. It's just that I have to go out for 2-3 hours in between for a family commitment. So what I'm going to talk today is to set the scene. This symposium will have two aspects. One will be discussing the GLP-1 analogs, and then we'll be talking about the long-acting insulins, and then there will be a talk combining the two, whether there is any role to combine these two. I'd like to say that I have received honoraria and research grants from many companies, including Novo Nordisk, which is sponsoring this particular symposium, and I hope there will not be too much of bias in what I talk. So let me start with this particular slide. What are the characteristics of an ideal anti-diabetic agent? So if we have a drug which is, of course, has glucose-lowering properties, it has less hypoglycemia, if it is weight neutral, or preferably if it can induce weight loss, and let me tell you there are very few drugs which can do that among the anti-diabetic drugs. If it helps in BP reduction, today FDA says that all anti-diabetic drugs must be tested for their cardiovascular safety, and this came after the rosiglitazone story. So if it has cardiovascular benefits, that's good, but at least it should be cardiovascular neutral. In other words, it should not produce cardiovascular disease, and it should have minimal or no side effects. Then it's an ideal anti-diabetic drug. Probably there is no such ideal anti-diabetic drug because one or two problems could be there. But which are the safest of these agents is what we'll try to see. I'm going to specifically talk about the incretins in diabetes therapy, talking about the non-insulin anti-diabetic injections, which are the GLP-1 analogs, exenatide and liraglutide, and also passing mention about the DPP-4 inhibitors, because later this evening I'll be talking a little bit more about the DPP-4 inhibitors. So why are these class of drugs different and how are they useful? The major difference as I see it is that many drugs act on the beta cells and either release insulin or improve the action of insulin. But these drugs, the incretin group of drugs, have one additional action, and that is on the long neglected alpha cells of the pancreas, glucagon. We know that glucagon levels are excessive in diabetes, and these drugs tend to reduce the glucagon levels. Now, this is what is called as the incretin effect. So, if you see, in response to what we eat, if the insulin levels go up, that is what is called as the incretin effect, and this is predominantly driven by the gut. And we also know that this incretin effect is reduced in people with diabetes. So if you see people without diabetes, the normal healthy controls, they have a much better incretin effect, whereas in people with type 2 diabetes, this incretin effect is blunted. We also know that glucagon levels are elevated in people with diabetes, and if you look at the comparison here of the non-diabetic subjects and type 2 diabetic subjects, there is a clear glucagon excess. So if there is some method by which a drug can reduce these glucagon levels, it makes the job of insulin that much easier. And that's the basic philosophy of the incretin-based therapies. Now, are all the incretin-based therapies the same? Well, basically what they do is that they prolong the half-life of GLP. This is not a native GLP, but it's an analog which mimics the action of the native GLP. So you have the GLP-1 receptor analogs, and you have liraglutide, which is a human GLP-1 analog, and then there is an exendin-based therapy, which is exenatide. Then there are others which increase the levels of native GLP, and these are the DPP-4 inhibitors, the gliptins as we call them, and this we will not be considering much here. We have heard several times from this morning that diabetes is a complex, multifactorial disease, and every 2 years a new defect is being identified in type 2 diabetes. Right now we have at least 8 defects, at least, which are present in people with type 2 diabetes. And it's heartening to note that the GLP-1 analogs address 6 out of the 8 components of the so-called ominous octet of diabetes. Now, where do we place these GLP-1 analogs? Of course, according to almost every guideline in the world, after lifestyle, it's metformin. And after metformin, most of the guidelines, the ADA guidelines, for example, or the EASD guidelines, for example, give us a wide choice. So you are free to use a sulfonylurea or a TZD or a DPP-4 inhibitor or SGLT2 inhibitors, the new kids on the block, or the GLP-1 analogs, and indeed even insulin if the patients have severe glucotoxicity. Even at that stage you can use. So right up there we have a choice, and therefore today it's not that we don't have choice of drugs, it's that we have too many drugs, and therefore we have to choose which patient will be suitable for a particular topic. So GLP-1 analogs can be used right after metformin, it can be used after sulfonylureas fail, it can be used even after insulin is initiated. The next question is, are all drugs among the GLP receptor analogs, are they all the same? And we have different drugs. We have exenatide, lixisenatide, liraglutide, albiglutide, dulaglutide, semaglutide, etc. So which one of these should we use? Basically, you can divide the GLP-1 analogs into short-acting drugs and the long-acting drugs. And among the short-acting, you have exenatide and lixisenatide. Whereas in the long-acting, you have all the rest with liraglutide, dula, albi, semaglutide, and the exenatide once weekly. If you classify them in another way and just say, if you classify them based on the duration of action, clearly exenatide is the shortest acting one and therefore has to be given BID. Lixisenatide is also short acting. Liraglutide is typically a long acting one, can be given once a day, but there are also preparations now which can be given once a week, and people claim that these drugs given once a week work just like the shorter acting or the OD dose ones. Now it's important to remember that the short acting analogs and the long-acting analogs have slightly different actions. Now, this is an oversimplification, but basically what it means that the short-acting drugs, because they're short-acting, have better effect on the postprandial glucose levels, whereas not so good on the fasting because they're short-acting. Whereas the other way around, one would expect to be true for the long-acting ones. Because of their longer action, they will bring down the fasting glucoses better, but the postprandial glucoses may not be that good. Now let me talk about liraglutide itself. There are numerous trials, the LEAD 2, LEAD 1, LEAD 3, LEAD 4, LEAD 5, LEAD 6 trials, and each of these trials on liraglutide have looked at different timings of introduction of this agent in the natural history of diabetes. In other words, just after metformin sulfonylurea combination, after TZD and metformin combination, and so on and so forth, and even as monotherapy. And you can see that the good news is that irrespective of when you introduce it in the natural history of diabetes, it seems to have an A1C lowering, which is fairly comparable. So at any stage of the natural history, it seems to work. Next, what are the proportion of patients who reach an A1C target of less than 7%? Again, the good news is that in all these trials, you can see that the percentage of patients who reach the target is very similar, irrespective of when you introduce it. To give it as monotherapy also it works, after metformin it works, after sulfonyl metformin it works, so it can be given at any stage in the natural history. The other very big beneficial effect is that consistently studies have shown that there is a blood pressure lowering effect of liraglutide. Now this is a pleiotropic effect over and beyond the glucose lowering or the weight reduction with liraglutide, and any reduction in blood pressure is useful, and clearly studies have shown that there could be reductions up to 4, 5, 6 or 7 millimeters of mercury reduction once you use liraglutide. Again, the big advantage of liraglutide, to my knowledge, there are only two groups of drugs which actually help you to lose weight. One is the GLP-1 analogs, which are injectables, and the other are the new drugs, the SGLT2 inhibitors, which are oral drugs, which also help you to lose weight. Some others are weight neutral, for example, metformin or the DPP-4 inhibitors, and almost all other drugs that you can think of, sulfonylureas, pioglitazone, insulin, whatever else you give, there will be a slow but sustained increase in weight, which is not desirable in the treatment of diabetes. So this is a classic example where if you compare a group of patients treated with glimepiride and treat them with liraglutide, if you look at the A1C reductions, they're virtually identical in this trial, but see what happens is that the weight in the glimepiride arm keeps going up, whereas in liraglutide, here up to 2 years, there's a consistent reduction in weight, and therefore if you look at the weight differential, it may translate into 3, 4 or more kilograms weight reduction between these two groups because of their differential actions. New data now emerging, which we need more studies, but very encouraging, is that some of these agents may actually have beneficial effects on the beta cells. So again, drugs like sulfonylureas, always suspected, does it increase apoptosis? Does it lead to early deterioration? Does it damage the beta cells? Is the beta cell, is there durability of action with these agents and so on? We have these class of agents which are coming in both incretin groups, but particularly with the GLP-1 analogs and particularly with liraglutide, showing you that perhaps there could be some improvement in beta cell function when these drugs are used. Whether these are because of their effects on glucagon, because of their effects on weight reduction, or due to independent mechanisms, we don't know, but there is good animal evidence and now emerging human evidence that perhaps they are more friendly to the beta cells. The big question is about pancreatitis and pancreatic cancer with this whole group of agents. Well, the pancreatic cancer story is slowly going away because we have study after study telling us that it's extremely, extremely uncommon, and the number of human pancreatic cancers reported after these agents is too small to be significant. But there's always this background noise of pancreatitis, and this has been examined again and again. There have been separate NIH meetings which have been held. The jury is still not completely out, but in general, what all associations have said is that we have to keep watching out for that, whether there is some little background activity of pancreatitis. But as of now, it doesn't seem to be severe enough. FDA still hasn't given a warning. After all these years, there's not a single warning actually given that it can produce pancreatitis. An NIH team was commissioned last year. They met, deliberated for 3 days and said, as of now, this is last year, as of now, there is no increase in pancreatitis, but they have said more studies need to be done. So in the background of somebody having pancreatitis, definitely you should not use these agents. But whether per se, we just heard that diabetes itself produces pancreatitis from the earlier speaker. So whether these drugs actually produce pancreatitis, we don't know. But it's very unlikely, and if at all, as shown by this meta-analysis, the risk is probably very small. You know, if you have a forest plot like this, anything which crosses the midline means it is not significant. If it's clearly on one side, okay, it means it is significant. Look at all these studies, virtually none which doesn't cross the midline, and therefore the risk, if at all, is going to be very, very small. I'm just going to show you one case of a patient whom I used many years ago. This is a 39-year-old man who came from Oman in Muscat. 10 years duration of diabetes. He was on glycoside, he was on metformin, and he was taking 134 units of insulin in 3 divided doses. Okay, he's a big man, already overweight, his blood sugars, he had uncontrolled diabetes, his weight was 105 kilograms, he was 223 milligrams fasting, 254 postprandial, A1C was 11.2. So at that stage, I said, we didn't have too many of the newer drugs at that time, this was a few years ago, and I said, what's the point in increasing his insulin? He's already taking 134 units of insulin, his weight is going up, he's on a sulfonylurea, weight is going up. Why don't we just reduce the dose of insulin and add liraglutide and see what happens? So I just stopped the 2 doses of insulin, just gave him 1 dose of Lantus at night, Largine at night, and added liraglutide in the morning and continued the same dosage of the oral agents. And this is what happened. His weight started coming down, 105, 100, 98, 92, 90. 15.5 kilograms weight reduction in this man. You may say maybe he changed his diet. He's an Omani, very few change their diet. Second is that maybe he did exercise. That guy can't even walk. He's got a neurological disorder which prevents him from walking. He does 0 walking. He's only confined to his bed all the time. So it is not diet and exercise which made him lose weight. Almost all of this weight loss I would attribute to 1, reducing the insulin dose, and number 2, adding liraglutide. Now, will everyone lose 15 kilograms? No, they will not. I'll show you some of my data. This is an exceptional case. But look at what happened to his A1C. Here is a guy who was taking 134 units of insulin. His A1C was 11.2. It dropped to 7.7 and 7.4. And his fasting has come down to 108 and his postprandial to 180. So these are dramatic responders. And so I would put it to you that when you have a difficult patient and you have newer drugs like this, whichever the new drug, even there are the SGLT2 inhibitors which I use now and some of my patients respond beautifully. Doesn't mean everybody will respond. And they are expensive drugs. Use them carefully, but don't be afraid to use them. These are what drugs are for. I'll just show you a small study which we did, 650 patients, where we had 117 patients on regular follow-up, long-term follow-up. And so we classified them into 2 groups. We had one group which is responders, weight loss as well as A1C reduction. Second is weight loss but no A1C reduction. Third is HbA1c decrease but no weight loss. And the fourth was neither the A1C came down nor the weight came down. So this is a real life study. And weight loss is defined as anything more than 1 kg we defined as weight loss, and A1C more than 0.5 we defined as an A1C decrease. So if you look at these cases, the best situation is here. The weight also came down, A1C came down. That's about 40% of the cases that I tried. Now this is a biased data. These are only patients who needed it that we gave it. This is not a routine randomized clinical trial. But about 40% of patients responded. Weight coming down but A1C not coming down, another quarter of patients. Weight didn't come down but A1C came down 13%. But 25% of patients both didn't come down. Neither the weight came down nor the A1C came down, and after 2-3 months we stopped the drug because it's too expensive, it can't be used. So here are these patients. If you get either of these, if you get either weight loss or you get A1C reduction, I would be happy. Because to bring down A1C, there are other drugs. Okay? So if either of them works, or at least A1C comes down very well, then you can use them, and a significant number of patients do that. Okay? So that's the total number in whom it came down and so on. Okay, so if you just compare this head to head with sulfonylurea, this is Defronzo's work, where he shows that if you look at durability of action, sulfonylurea is not so great, this is better. Beta cell preservation, certainly not with sulfonylureas, yes with incretins. Hypoglycemia is there with sulfonylureas, you very rarely get it with this. And weight gain is there with sulfonylureas, you actually have weight loss with these agents. So I would just throw up one more algorithm for you. This is my own. Okay. So if lifestyle and metformin you use an A1C is more than 7 and the patient can afford it, and I'll put that right up front, and if the patient is obese, try liraglutide. Why not? It's one of those agents you can try. If it's non-obese, then you try a DPP-4 inhibitor. The patient cannot afford, then you use a lower dose of sulfonylurea. Don't load them with sulfonylureas. Try to use a slightly lower dose, and then patients can do well. And all that doesn't work, of course, our good old friend insulin is available there. So I would like to actually summarize here, ladies and gentlemen, by saying that type 2 diabetes is a progressive disease involving numerous interconnected disease pathways across multiple organs. GLP-1 is a native hormone with glucose-dependent effects effects on various aspects of glucose homeostasis. GLP-1 response is impaired in individuals with type 2 diabetes. Drugs that enhance the GLP-1 response in individuals with type 2 diabetes are among numerous therapeutic options are now available. GLP-1 receptor analogs are different with respect to size, structure, and pharmacokinetic profile, and these differences can have impact on the efficacy and tolerability. And in comparative trials with other GLP-1 receptor analogs, liraglutide has been shown to have unsurpassed A1C reductions and weight lowering effects in selected individuals. And I think I'll stop there. Thank you.
Thank you, Dr. Mohan, for as usual excellent delivery. The session is open for question answer.
Okay, so one is a observation which says that the major advantage of liraglutide that it's cardiac friendly. And then second question, why is that some did not respond? So I'll take the first one first. Well, we don't have the data yet. It's coming. So we hope that it is cardiac friendly. As of now, all the cardiometabolic risk factors, it is definitely friendly. So it's reducing the blood pressure, it's reducing the weight, it's reducing the glucose. So it seems to have beta cell friendly. So all the portents are good, but you never know until the long-term trial is published. Hopefully next year. Next year, I think we'll have the final results of the long-term cardiovascular safety. I would put it to you that even if it is neutral, like TCOS was, as far as sitagliptin, that's fine. We are not giving liraglutide to prevent heart attacks. We've got statins, we've got aspirin, we've got so many other things. So as long as it doesn't do harm, I would be happy with any. The anti-diabetic drugs were not meant to prevent heart attack. Then they would be cardiac drugs. They're not diabetic drugs. As long as they don't do harm, then that's fine. Regard to your second question, why some responded, I don't have the answer. I don't think even the company has the answer. Like everything in medicine, some people respond to certain drugs. We know that with every drug. You give pioglitazone to somebody, it will dramatically bring down 4% A1C. Give it to another guy, nothing happens. Okay, it doesn't come down at all. One guy will put on 20 kg with pioglitazone, another fellow won't put on weight at all. We don't know. It's probably some pharmacogenomics which is involved. There are people with sulfonylurea respond for 40 years. We say durability action goes up. In my long-term diabetes paper, which I published 40 years duration, everybody used sulfonylurea only. At the end of 40 years, they're still on sulfonylurea. They responded very well. So like that, we have to study. As we understand pharmacogenomics a little bit more, we'll begin to understand why we don't have a marker right now. But if they have fairly good C-peptide, they seem to do much better. If it's completely burnt out, no C-peptide, these drugs don't work so well. Sorry? Dose. Well, it's certainly dose dependent. So you start off, when you use liraglutide, always start with a small dose because of the nausea and vomiting. So you start with 0.6. I give 1 month at least before I go to 1.2. I'm not in a hurry to increase it because slow and the Japanese start with 0.3 actually. We start with 0.6. So wait for a month, then increase it to 1.2. You can go up to 1.8. I don't usually use 1.8 in my patient, but somebody is really responding very well and he wants more weight reduction, then we need not be afraid. After all, for obesity, they're using 3 milligrams. Not even 1.8. So I think 1.8 you can use, but in Indian patients, mostly 1.2. If you want, you can use 1.8. The effect is definitely dose dependent. Okay? But there are some who with 0.6 and 1.2 will respond very well. There are others 1.8 don't respond at all. So there are non-responders. So you'll quickly know in practice. As you start using, you'll quickly know who the first visit or follow-up visit, you'll know who's going to respond. So we say liraglutide responder, we'll write on the case sheet. So those patients we will continue. Something in the back, yes sir.
Actually, GLP-1 receptor has got also positive inotropic effects.
Yes.
As you have rightly told, these are not used as a drug for the heart.
Exactly.
But those patients who are using liraglutide with heart failure, they are having better response in terms of the positive inotropic effect.
Absolutely.
And some cardiologists are also utilizing this.
Absolutely.
Yes.
Yeah.
Yes, your question?
Yeah, so
I think we'll take that question.
Sorry, sir. It's like asking a question to a textbook. I'm asking one question to you. Like you projected one slide which showed there is a precipitous drop in the A1C.
That patient?
The same case study.
Yeah.
Is there any time frame that we have to fix on certain agents which we are using in diabetes? Like one for liraglutide and another one for insulin.
You mean to see whether they respond or not?
No, traditionally we say once in 3 months or 6 months like that.
So I would say that, typically an A1C is repeated after 2 to 3 months, isn't it? So if you wait for 2 to 3 months, now that particular patient was a peculiar guy because he came from Oman, from the Oman government, and he was in my hospital for 2-3 months. That's why we kept, doing at periodic intervals. So that is the point we did the A1C a little earlier probably. That's because the guy has been hanging around for so long, I want to know what's happening to him. But typically we do it after 2 months. So after 60 days would be the earliest you need to do. If you are not able to get a response at that time with any of the newer agents, it's very unlikely that they're going to be great responders. You start a new drug, you give an SGLT2 inhibitor, and after 2 months A1C has gone up. If you say, no, I'll wait 1 year, it'll come down, it's very unlikely. That he is not one of those who's going to respond to that particular group of drugs. And cost is a major factor. Patient himself will say, sir, no sir, we'll stop, I'll go to something else, it's too costly for me. Whereas if they see a response, they see a beautiful reduction in weight and they see a beautiful reduction in the A1C, even if it's costly, they say, okay sir, but it's working so well for me, I've never seen these kind of readings, let me that particular patient, the Oman patient, is like a miracle for him, He is able to stop 2 insulins and then lose so much weight, A1C coming down, he will continue it for a long time.
Whether the weight loss is continuous and sustained?
It sustains, but it doesn't go on losing weight like bariatric surgery.
Yes.
So you will lose, some will lose 3-4, some will lose more, and then it will kind of steady out. We don't have very long-term results, but after a year or 2, there may be a slight pickup in the weight. It also depends on lifestyle, obviously, what he takes, and depends on the other drugs that you use, depends on insulin dose that you use, it depends on the caloric intake, whether they exercise, all these factors. But it is a fairly significant, and up to 2 years, 3 years data we have that it is fairly flat. There may be a slight increase, but you cannot compare it with bariatric surgery, where you lose 20-30 kilos and for years, 20 years, the weight may not come back.
Another thing is that giving for 6 months or so and again going back to the older drugs which the patient was taking, your suggestion.
It's like giving a statin for some time and then withdrawing it. The effect will be there only as long as, it's not that you give for 6 months and then metabolic memory will take it going for another 1 or 2 years. These drugs always work only as long as you give it. So once you start it, you have to continue it.
Actually, one separate preparation of 3 milligram liraglutide known as Saxenda has been marketed
obesity.
outside, will be coming soon. This
For
will
obesity,
be used for obesity only, not diabetes.
Yeah.
Yes. I think this should be the last question.
Last question. Well, the overall lowering, as I said, it's not a BP drug again. So we are not giving this as these are all extended benefits. If they come, it's good. Okay, tell you one more bonus effect I got. It's like that. You shouldn't use it for BP reduction. We've got so many BP drugs. Why would you use liraglutide to reduce? But imagine if there was another drug which you gave and it increased the BP. Obviously, you don't want that. Suppose it's fluid retention and your BP goes up. So compared to that, this will be definitely good. But we are not promoting it like a BP lowering agent. And in normal people, see, always like HbA1c, let us say. You start somebody with a HbA1c of 11. Now that guy was able to reduce 4%. Suppose his HbA1c is only 8. Can you reduce 4%? Will it go to 4? Definitely it will not. So the starting HbA1c will depend the fall. Similarly, the starting blood pressure will determine. Suppose it's a hypertensive patient, 180 systolic, you may get an 8 millimeter drop in systolic. If it's 140, you won't expect 8 millimeter. You may get 1 millimeter drop in blood pressure. So everything in nature will adjust itself. If you do bariatric surgery, somebody is 150 kilos will lose 50 kilos. If he's only 70 kilos, we lose 50 kilos, become 20 kilos, that won't happen. So from 70, he may become 55. So that nature will take care of that. The body has such fantastic thermogenic and thermostat mechanisms, it will take care of that. Remission. Probably if you do it in pre-diabetes or very early stages, you may see it, but I don't think we have the data and it's completely off-label. It's not yet approved. So getting a total remission with the liraglutide, I have not seen data. There are 3 cases, 3 papers. 3 mg. Okay, but that's mostly given in non-diabetic. So if you use that in pre-diabetic individuals or very early, the remission is certainly not comparable to bariatric surgery again, because there the weight loss is 20, 30, 40 kilos, which you don't get with liraglutide. It's beneficial, it's good, it has its benefits, but again, we may not get a remission of diabetes in many cases.
We should conclude here.
Yes, sir.
This is enough question answer. Thank you, Mohan.
I wish to thank you, sir. I wish to thank the chairpersons for allowing me to go, and also I crave indulgence of the other speakers if I have taken some of their questions ahead. But when you ask other questions, you can leave these questions.
No, Mohan, if we don't
thank
have
you
a
so
question,
much.
it will be a problem for us from the audience. So I request you to join big hands for Dr. Mohan.
Thank you.
As usual, excellent presentation. Dr.Banshi to call the next speaker.
Thank you, sir. Thank you. For giving next talk, which will be on developments in basal insulin therapy, the newer insights, Dr.Awadhesh Kumar Singh from Kolkata, who is a chief consultant endocrinologist and diabetologist at Sun Valley Diabetes Research Center and Hospital and GD Hospital and Diabetes Institute at Kolkata and Guwahati respectively. He got Dr. T.N. Ghosh Memorial Award and Medallion Scholarship. He is a speaker and chairperson for many national and international conferences and very regularly to API, RSSDI, Endocrine Society of India and many more national and regional meets as well as for international forums. He have more than 50 publications and very close friend of us, Dr. A.K. Singh, who is going to talk on development in basal insulin therapy. Over to Dr. A.K. Singh.
Thank you, Dr. Banshi and Professor Samar Banerjee, who is my teacher during my postgraduate time, and I still look him as my teacher. Thank you, Dr. Jothydev and team, for inviting me back in last successive 3 years to give a difficult topic of deciphering the differences among the basal insulin. You know, it is always a difficult job to get sandwiched between two speakers who has been awarded Padam Shri, Professor Mohan, and followed by me, Dr. Shashank, if he can make it on time. He is on the way right now. But I would do justice to my topic, although this is a Novo-sponsored symposium, but then I will not deviate from a basic instinct that science is always, one has to prevail. So I will look into differentiating between a basal insulin analog in particular. This is a very interesting area. I did 3 publications. I wrote 3 review articles on basal insulin analog and 1 on premix analog. So I worked very closely with this particular topic. Well, so when you look into the evolution of modern basal insulin analog, the story goes back to NPH in 1942. For 50 years, since 1942 up to 1992, you had no other choice but then using NPH insulin. So it took almost 50 years to find a newer modern insulin analog from NPH in 1942 to 1992, the insulin glargine U100, popularly called Lantus. But then, since 1992 to 2013, you have got a number of modern insulin basal analog. But the big question is why we need so many analogs. There must be some problem with existing insulin analog. So I'm talking about the basal analog here. So my duty would be to look into their trials and tribulations of what we could have learned from these modern insulin analog. So when you look into insulin glargine first, so naturally, once insulin is manufactured, they go for asking the approval from United States FDA. So they conduct the trial. So I have divided to make you understand how to understand different basal insulin analog. So I have classified the insulin and their role into 2 parts, as a pre-FDA approval trials and as a post-FDA approval trial. So if you look into the glargine, when they were seeking FDA approval, they did 8 trials, which is typically called study A to H. And then after the FDA gave them the approval, they conducted number of trials and then their tribulations in the form of meta-analysis. Same thing happened with the Detamir in 1996 when they seek US FDA approval. They conducted 6 trials called study A to F. And once they got the approval, number of studies conducted and their meta-analysis were done. And I will show you 1 slide each to understand what happened in these trials. Degludec, another insulin, they have not been given the US FDA approval, but right now there have been approval in 42 countries, including in European Union, India and Japan as well. So they have also asked for FDA approval. They conducted 8 trials. This is called Begin trial. The 7 trials were conducted head-to-head with glargine and 1 trial versus their own product, called Detamir. Now, newer kids in the block is insulin, is called pegylated lyspro insulin from Eli Lilly, and they have undergone a pre-FDA approval trial, which is called Imagine trial. There are 9 Imagine trial. The most of them, the 6 Imagine trial result was published this year in AD at Boston, and I will give you a glimpse of what this insulin is look like, what is the advantage about this insulin with the existing one. And finally, now we are having a 3 times concentrated preparation of insulin glargine called glargine U300. Earlier Lantus you were using is U100. So this is called glargine U300. And they also are looking for trials called Edison trial. They have got 6 trials. Of them, 4 of the trials and their result is already available with us. So I will go one by one, starting from NPH to glargine U300 to make you understand what's the reality in terms of outcome. So this is a study, we reviewed it and published it. You can see this is a pre-FDA approval trial. As I told you, there are 8 trials of insulin glargine, insulin NPH when conducted with glargine head-to-head. And when they compared glargine and NPH in different parameters, remember these were not a treat-to-target trial. In that era, you did not require treat-to-target trial. These are simply efficacy trial. What is interesting to note that if you see here, what was the difference in terms of fasting plasma glucose or HbA1c or the dose requirement or hypoglycemia, any hypoglycemia, whether it is a severe hypoglycemia or overall hypoglycemia, there was hardly any difference in this head-to-head trial versus NPH and glargine. Then one can ask this question, then why glargine got the approval? What is the benefit you got it? Why you need another basal insulin when NPH was there? Actually, in the pre-FDA trial, they did not get any benefit whatsoever in terms of even a hypoglycemia. And to be interesting to note that, in fact, in 2 trials, the insulin glargine had a higher hypoglycemia compared to NPH. And I have marked here in trial C and E, there was higher hypoglycemia in insulin glargine arm compared to NPH. And even in this study, the hypoglycemia definition was defined as a sugar less than 50 milligram per dl, except in one study where it was defined as less than 56. What was the problem with glargine even in their pre-FDA approval trial? That pain at the injection site were 4 times higher in insulin glargine arm. You know the glargine has acidic pH and pH is soluble. So there were 4 times higher pain at the injection site compared to NPH. And I also thought to give you one data because many people tend to write insulin glargine in the morning. Although there are some trials where morning glargine were compared with evening glargine. And clearly we find that evening glargine looks to be more efficacious compared to the morning glargine dose. Although it's a long-acting insulin, you can use at any point of the time. But the evening glargine was found to be better in terms of HbA1c reduction compared to the morning. As you can see, even 5% in the glargine breakfast arm discontinued because of lack of efficacy. So prefer to use glargine in the evening time or bedtime. Now, when you see the trials of NPH versus glargine after the FDA gave the approval, there was a clear benefit. What is interesting to note that not only the hypoglycemia benefit, but if you look into the fasting plasma glucose, remember these are now treat-to-target trial after the FDA approval, and there was a clear benefit of nocturnal and overall hypoglycemia with insulin glargine compared to NPH. And to achieve the same level of HbA1c, the insulin glargine actually reduced fasting plasma glucose more than insulin NPH. And when you look into their meta-analysis of all these post-FDA trial, as you can see here, there was a clear benefit of hypoglycemia, whether it is nocturnal or it is overall severe, confirmed, all hypoglycemic outcome were superior with glargine compared to NPH. So this is the glargine and NPH story. When you look into the Detamir versus NPH story, it looks exactly the same. So this is a pre-FDA trial, 6 head-to-head trial, hypoglycemia defined as 56, except in 1 trial and 2 trial it was defined as 50. Again, you can see hardly any changes in hypoglycemic outcome here, or any outcome. NS means not significant in terms of hypoglycemia or the insulin dose. But when you look into the post-FDA trial and the number of trials conducted, there was a clear benefit of insulin detemir over NPH, whether it is hypoglycemic outcome or it is the fasting plasma glucose required to achieve the same HbA1c target in a treat-to-target trial. Detemir found to be better compared to NPH, as you've seen the same story with glargine versus NPH, and even in their meta-analysis, there was a benefit in all outcomes of hypoglycemia, including nocturnal, overall, and severe hypoglycemia. So this is the story of detemir versus NPH. What about digludec? So these are the pre-FDA 7 trials of digludec versus glargine. And now remember, so when we are comparing pre-FDA versus post-FDA, in pre-FDA trial, there was no benefit of glargine versus NPH, there was no benefit of detemir versus NPH, but see the story here, this looks a little bit different. So there is a clear case to understand that even a pre-FDA trial of insulin digludec head-to-head with glargine, there was a clear superiority, at least in terms of hypoglycemia, as you can appreciate here. Especially the nocturnal one. In some of the studies, even the severe hypoglycemia were lesser with digludec arm compared to glargine, and in some trials, even overall hypoglycemia was better with digludec compared to glargine. Furthermore, if you look into, because these are the treat-to-target trial, so you actually land up with the same HbA1c reduction. So how to understand which insulin would be superior? And the basic idea is to understand in terms of the dose required at the end of a study and the changes in fasting plasma glucose. As you can see here, the plasma glucose, fasting plasma glucose was better even in this treat-to-target trial. So to achieve the same HbA1c, you have got a better fasting plasma glucose reduction with digludec compared to insulin glargine. And when you look into the mean dose required at the end of a study, and I will go a little detail into that, you could find out that digludec required lesser doses of insulin compared to glargine to achieve same HbA1c. And if you closely look into the different 7 trials here, at least you can see in 5 out of 7 trials that the dose requirement of digludec were 10 to 13% lower. In one of the trials, in fact, it was 20% lower in the Asian populations here compared to insulin glargine. And further division of this classification of dose you could see here, both in basal and the bolus dose, there was 10 to 13% reduction in the both bolus and basal dose of insulin when the insulin digludec was compared with insulin glargine. And same happened in type 2 diabetes. As I said in one of the trial, it's called Begin Once Asia, there was a 20% lower dose of digludec compared to glargine to achieve same HbA1c target. Now then people criticize that, oh, you did the hypoglycemia definition by 56, although the ADA defines hypoglycemia by less than 70. Remember, so initially when the Novo Nordisk started the trial, and in all the trial, as I shown you, the hypoglycemia definition were either 50 or 56 in all this trial. If you see the current, insulin, basal insulin like pegylated lysport trial or glargine U300, now hypoglycemia has been defined at less than 70. So at the same time, when the digludec trial was conducted, the Novo Nordisk defined hypoglycemia like 56, what they did with glargine or did with detemir or with NPH. So when you analyze this definition of hypoglycemia, by changing the definition of hypoglycemia from 56 to 70 even, you could see here, there is a clear difference. Although the risk ratio has reduced maybe by 7 to 8%, but there is still statistically significant lower hypoglycemia with digludec compared to glargine, whatever may be the definition of hypoglycemia, whether it is 70 or 56. Then people also talked about the timing of hypoglycemia. How did you define hypoglycemia? Because you could have injected glargine on different time and digludec on different time, and you tried to measure nocturnal hypoglycemia by making your own definition of nocturnal hypoglycemia. So ideally, the nocturnal hypoglycemia is defined between 12 a.m. to 6 a.m. This is the actual timing. But then people say that there may be a difference in hypoglycemia. If you extend it by 2 hours prior or 2 hour post, you may get a different outcome because of the timing of insulin injections. So several studies were analyzed if the hypoglycemia definition could be preponed by 2 hours from 12 to 10 p.m. and if it can be postponed by 2 hours from 6 a.m. to 8 a.m. What changes you would get it when you are comparing digludec with glargine? Again, you see hardly any difference. Maybe it has reduced in one study and it has been better in another study. So overall, it is still statistically significant, whatever the timing of definition you would like to do for nocturnal hypoglycemia. As we know, the US FDA has not given them the approval because they asked for a CB safety trial, and they are undergoing the trial called DEVOTE trial, and we are expecting their interim result very soon, how degludec is doing in terms of CB safety data. And this is why the US FDA has not approved them. But that is not a big issue. Vildagliptin has never been approved by US FDA, but is the most popular drug used in clinical practice. So FDA approval may not be the bar for clinician to use particular drug when the drug is approved in EMA by European Union, in India or in Japan. But then definitely any robust industry people would like to seek their opinion from US FDA and get their approval approved. So when I analyze all this trial into this meta-analysis, you can clearly find out that glargine was better to NPH in terms of nocturnal hypoglycemia, detamid was superior to NPH, and degludec is superior to glargine in terms of at least nocturnal hypoglycemic outcome. Now, next kid in the block is pegylated Lispro insulin. This is manufactured by Eli Lilly. What is this insulin? I will just go through a few slides on that. This is insulin Lispro. The Humalog insulin which he used is actually assembled with polyethylene glycol chain to make it a larger size. So actually it's a 6 kDa protein is insulin Lispro. When it is added with a polyethylene glycol, this is 20 kDa. So total you have got a 26 kDa size of pegylated Lispro. Because it absorbs 3 molecule of water, you multiply 26 by 3, so it becomes approximately around 80 kDa larger size of pegylated Lispro. It has got different nature. It is not exactly like Lispro, because we had some concern with Lispro they have because of their affinity to the insulin receptor and the IGF-1 receptor. Some of the studies suggested increase in retinopathy with insulin Lispro, but in case of pegylated Lispro, their affinity is much lower than insulin Lispro, and because of this increase in size, they have got slow diffusion and a little bit slower renal clearance as well. And because of their size, there is a preferential hepatic intake. That's why it's called hepatic insulin. It has got some property to enter into the to liver to act through, which actually we are looking for. We are looking for insulin which actually works through a portal circulation rather than a systemic circulation. We could have actually get all the side effect of insulin out from the all the insulin. So that's why this insulin is called a hepatic insulin, with expectation that all the systemic side effect of insulin would be reduced with this insulin. So what happens in this insulin pegylated Lispro? When you look into the PK/PD data of Lispro versus glargine, you could clearly find out it is flatter compared to insulin glargine. Without any peak, it is flatter, it is longer compared to glargine. So these are the trials. As I said, there are 9 trials called Imagine trial with pegylated Lispro, of which 6 trial has been published, and I will give you a glimpse of what happened in these 6 trials. So what we learned from this head-to-head study with glargine, that pegylated Lispro for the first time was found to be superior even in a treat-to-target study compared to glargine in terms of HbA1c reduction. Remember, degludec was equal to glargine in terms of HbA1c reduction, but for the first time through a non-inferiority trial we could achieve a superiority through the pegylated Lispro. That is a great news for the pegylated Lispro. They had a better HbA1c reduction, lesser nocturnal hypoglycemia. In some trial there was weight loss or less weight gain compared to glargine. However, there was more safety issue still pending with pegylated Lispro. As you can see, this is a hepatic preferential insulin, so they tend to increase the liver enzymes like SGPT, they tend to increase the triglyceride, they tend to increase the hepatic liver fat. So these are the big issue with pegylated Lispro. And also, although they had a better HbA1c reduction, better nocturnal hypoglycemia, but the overall hypoglycemia and the severe hypoglycemia requiring third-party assistance were higher in the pegylated Lispro arm compared to insulin glargine. This is overall, if you look into this 4 trial here, or imagine 5 and 6, almost similar picture of side effect: increased TG, increased SGPT, increased LFT, increased fat in liver, and increase in severe hypoglycemia with pegylated Lispro compared to glargine. Now, what few words about glargine U300. This is exactly the same insulin of Lantus, which has been concentrated into 3 times to make the volume of insulin smaller. If you give a lesser volume of insulin, you tend to utilize the larger surface area and to get an entire absorption. So it would be better for those patients who are requiring very high dose of glargine, you can shift them to this U300 glargine. And this is just PK/PD data, and I'm not going to detail, but let's come to the point that actually the Sanofi thought that we are going to make a longer acting insulin glargine compared to U100. But it has not become that much longer. It has only gone to the extent of 3 to 5 hours longer than the original U100. But what the ground they lost is the bioavailability of this insulin. So they found that by making 3 times concentration, we are losing 60% of the bioavailability of this insulin. And that's the problem with insulin U300. As you can see, I'm going to show you some data. The dose requirement with U300 is around 10 to 12% higher compared to U100 insulin glargine. So this is their phase 3 program. This is called Edison, and all these 4 trials data is already now available in the public domain. It has been presented this year in ADA Boston. I will just show you one study. It's called Edison. Why I wanted to show you this study is see the difference in terms of fasting plasma glucose in the first 8 weeks in Edison 1 trial. You see here the fasting plasma glucose was better with U100 compared to U300. And at the end of a study, if you closely look, there was a higher 10 to 12% insulin requirement with U300 compared to U100. And also there is a improvement in nocturnal hypoglycemia. This is my last slide. But this was inconsistent in nature. As you can see, in the first 8 weeks, there was some hypoglycemic benefit, but when the trial was conducted for a longer period of time, and this is a summary slide to make you understand, there was hardly a huge difference in terms of dose. There was high requirement. Hypoglycemia was there, but that looks to be a little bit inconsistent. So to conclude, ladies and gentlemen, what we have learned and what I have talked in this 20 minutes of time, the glargine and detamir are clearly an improvement over NPH, being longer acting, used once daily, lesser variability, lesser nocturnal hypoglycemia when you compare to NPH. Unfortunately, detamir often required twice daily injections and the larger dose, and both glargine and detamir cannot be mixed with other shorter acting insulin. So that's the biggest problem with the older insulin. The Digluduc at this point of time looks to be the most improvised, with the better flatter profile, least variability, once daily, flexible timing, less nocturnal hypoglycemia, and the most important to me is you can mix with any other insulin, including the GLP-1 agonist. Next speaker is going to talk on that. Glargine U300, as I said, inconsistent benefit in terms of hypoglycemia, but the dose requirements are higher. Pegylated Lispro looks to be good. It actually beaten insulin glargine for the first time, but they do have many safety issues, as I discussed, including higher dose, increase in SGPT and triglyceride. Thank you very much for your patience here. Thank you so much.
Now I invite Dr. Jothydev Kesavadev, who is the main person behind this conference. There is a big biodata. I think it is not necessary here, which I think most energetic person, if not the superstar of Kerala in diabetes, and always academically oriented. But what the peculiar thing, I look at him, he can laugh always. I don't know whether during sleep he also laughs. When he is irritated, he laughs. When he is pleased, he also laughs. The best laughing personality with major contribution in diabetes academic world. He has contributed to our Journal of Clinical Diabetology. He is going to contribute in the next upcoming RSSDI Handbook of Diabetes. Jothydev Kesavadev, very e-friendly personality, will speak on finding new directions with insulin GLP-1 agonist as an add-on or in combination. Jothydev, please.
Thank you. Thank you, Dr. Ashwin. And respected Chairperson, Dr. Samar Banerjee, the key opinion leader from Calcutta and editor of several journals, a well-wisher and a mentor for us. And once again, welcome to all the physicians across the state of Kerala and from neighboring parts of Kerala. And we are extremely privileged to organize this convention, and we are expecting Dr. Shashank Joshi to join us very soon. And that's the reason why I have taken this topic before him. In the management of diabetes, in the usual scenario, when a symptomatic patient with uncontrolled sugars, when he is kept on insulin, when you are up-titrating the dosages of insulin, and when he returns with absence of symptoms, this is a scenario where you share the sense of happiness and satisfaction. But the scenario need not be the same all the time. In contrast to the usual happiness, these instances can also happen in real life, though this is a cartoon. And this is a guy who is put on insulin and has gone back to the doctor and is threatening him. Why didn't you put me on liraglutide, which could have otherwise reduced my body weight? And this again is the result of patients having access to the emerging knowledge on evidence-based medicine, on the safety and efficacy of newer medications and technologies. Over the years, we have been using several medications for diabetes. Listed here, you have the metformin, GLP-1 gliptins, you have the TZDs, sulfonylureas. However, when you compare across the therapies, the A1C reducing potential of one medication, that is insulin, is unlimited, which is listed over here. And this cannot match with any other therapies. And because of this truth, insulin is going to exist in therapy of diabetes forever. And we do have evidence from the landmark clinical trials, and this is from UKPDS. No diabetes convention is complete without the mention of UKPDS. UKPDS taught us the lesson of how an initial intensive management of type 2 diabetes can translate to reduction in the vascular complications of diabetes. And that is not just in the short term. These benefits are going to persist even for decades. Despite the availability of evidence, despite the availability of therapies and devices, globally, diabetes still is a failure. These are the numbers. These are the critically raised numbers globally. However, when compared to the developed world, in India, we have those numbers which are really, really critically high. And studies have shown across South Asia, not even 4% of patients undergoing therapies for diabetes will have all the three parameters normalized. So, treatment of diabetes is globally a failure. What could be the reason for this failure? What are the major reasons for failure in the treatment of diabetes? The major reason for failure is the fear. And the fear can be multiple. The fear can be due to multiple reasons and complications. However, the major fear is the fear of hypoglycemia, which is shared between the physician and the patient, which is there existing across almost all the therapies. And this is a cartoonistic representation of a hypoglycemia being managed at home. The fear of hypoglycemia is compared to, in this study and in many other studies, almost equal and high as the fear of developing some of the complications of diabetes, such as renal failure and blindness. So that high is the fear of hypoglycemia for a patient with diabetes, especially those who have experienced at least one episode of a hypoglycemia. One of the emerging newer modalities in the management of diabetes is the assessment of glycemic variability. glycemic variability is closely linked to hypoglycemia. And here you have the data on how you can assess the glycemic variability. And this is with the standard deviation. With increasing glycemic variability, you have higher chances of developing hypoglycemia, which is independent of ambient glucose levels. And here you see a magic number of 1.7 below which the risk of hypoglycemia seems to be almost completely eliminated. And hence, the significance of assessing glycemic variability, which again is one of the common etiologies for the development of vascular complications in diabetes. And this is one of our own studies where we have measured the standard deviation, the MAGE and mean of daily difference in type 2 diabetes with the help of continuous glucose monitoring. Obviously, the data have shown the significance of glycemic variability, which is going up with escalating total daily dosages of insulin. In other words, when a subject is requiring higher doses of insulin, there is always a reason for glycemic variability to escalate. And the glycemic variability, which is now considered as the fourth metric in addition to the usual parameters of A1C, fasting, postprandial, is minimal or almost absent with the newer modalities of treatment, with the newer medications and with newer devices. What next? What is the next challenge in the treatment of diabetes? Why is diabetes therapies failing? Across the landmark clinical trials, we have UKPDS, we have ACCORD, we have VADT. Across all the clinical trials, when you intensify the management of diabetes so as to reduce HbA1c to the target levels, which again translates to prevention of the vascular complications of diabetes, there is a progressive increase in the body weight. And this is almost indispensable. Treatment of diabetes, when it is going to be successful, patients developing increase in the body weight. This is an animated slide where you have the picture and the animated representation of initiating therapy in diabetes with one oral drug, the usual conventional therapies. You go step by step, adding multiple drugs, and then insulin, then multiple daily insulin. And over the course of treating diabetes, you have the patient gradually gaining weight, and progressively there is an increased risk of developing hypoglycemia. However, in contrast to the conventional therapies for type 2 diabetes, which can result in hypoglycemia, which can result in weight gain, you have choices now. And this is a choice where you have the privilege of mixing the two time-tested modalities together. And that is mixing the basal insulin with GLP-1 RA. And this is the expression of happiness and satisfaction, a beautiful girl, to keep all of you awake. And don't miss the stethoscope over here. And this is the happiness and satisfaction of this complementary actions of these two modalities. Whether you add insulin to liraglutide or if you add liraglutide to insulin, you have the same benefits, the multiple benefits of A1C, body weight, and hypoglycemia. Over to a couple of our own studies. Here we have used liraglutide in newly diagnosed type 2 diabetes subjects to initiate therapy with GLP-1 RA and metformin. And in those on Victoza, there is a reduction in both fasting and postprandial. And there is a substantial reduction in HbA1c. At week 24, it is 5.52. And this again is another indication, and here you have the robust reduction in the body weight up to the tune of 8 kilograms at 24 weeks. And we even went to the extent of making this postulation in this publication, whether the use of Victoza in newly diagnosed type 2 diabetes patients can result in a possible remission of type 2 diabetes. So these are the merits of these new molecules, the GLP-1 RAs. And now, whether you can have a combination, the emerging evidence combining the two therapies together. And the rationale is very simple because of the distinct, stable association forms of these two molecules, liraglutide and insulin degludec. The glycemic control is ensured around the clock. Basal insulin will reduce the fasting glucose values. Liraglutide has got action on both, with more action on postprandials and steady titration possible. And the combination could be made available as a single shot in a single pen, and this is that revolutionary molecule. I personally feel that this is going to be the future of treatment of diabetes. Having these two molecules together in the same pen. And this is the name of that combination, Sultofi. Sultofi is a combination of Victoza with Tresiba. You have the 3 ml pre-filled pen over here, and the 3 ml pen will have 300 units of insulin and 10.8 milligrams of liraglutide. To simplify what I have said, this is the dosages. One dose step will have 1 unit of degludec in combination with 0.036 milligrams of liraglutide. And this will be the 10 dose steps, and you can go up to 50 dose steps in a single shot. 50 units of degludec will have in its combined with 1.8 milligrams of Victoza. Moving on to the clinical trial program of Sultofi. You have the landmark clinical trials over here, and these are the dual clinical trials. And dual stands for dual action of liraglutide and insulin degludec in type 2 diabetes. You have dual 1 to dual 5. I will briefly go through the clinical trial programs. And this is the emerging evidence with these combinations. Dual 1, these are the inclusion criteria. And in this clinical trial, in type 2 diabetes, you have 3 arms. The combination of degludec with liraglutide is compared with its individual components separately. And here it is degludec and then liraglutide. And in this clinical trial, if you look at the 3 groups, the 3 treatment groups listed over here, they were matched with respect to baseline clinical and demographic characteristics. For example, this is the BMI, matched in all the 3 groups. And with respect to HbA1c, there is a substantial reduction in the A1c with IDEC-LIRA combination at the end of trial, 52 weeks. And over to the reduction in the body weight. When compared to insulin degludec alone, at the end of trial, 52 weeks, there is a reduction of 2.8 kilograms with this combination. And what about the reduction in the dose of insulin and liraglutide in this combination to achieve the same target A1C value? This is again robust, clinically and statistically significant. There is a difference of more than 23 units of degludec in the combination when compared to when it is given alone. And the same is true with liraglutide. What about the side effects of Victoza in the combination? When compared to lira given alone, the side effects of nausea and vomiting gets almost eliminated when it is combined with insulin. And this is the study design of Dual 2. Dual 2 trial is again a very simple trial, and this combination is compared with those who were previously on a basal insulin and diabetes uncontrolled. And these are the two arms of the trial. And over here, you have the data on how and why the degludec component in the IDEC-LIRA combination has as a component providing additional benefits in A1C reduction, and this is demonstrated over here, and additional benefits in weight reduction in the combination, and with very low rates of hypoglycemia when these two are combined together. And this is Dual 3. Dual 3 is a trial where IDEC-LIRA is compared against GLP-1 RA agonists. In short, these are subjects who were previously on GLP-1 RA therapies, and they have uncontrolled diabetes. And in this clinical trial, they have added IDEC-LIRA in one arm, and others were on their baseline therapies. And you can see the significant difference. 75% of patients on Sultofi achieved an A1C below 7%, and 63% achieved an A1C below 6.5%. So IDEC-LIRA once daily has provided superior glycemic control versus those who were unchanged on GLP-1 RA therapies. So this is one efficacious approach in intensifying therapies on those who are now uncontrolled on GLP-1 RA therapies. Moving on to the next clinical trial, and this is a scenario, Dual 4. Actually, this is one of my favorite clinical trials. Why? Because this scenario is going to be the commonest scenario where you and me will be putting these patients on IDEC-LIRA combination. Why? Because these are the patients who were previously uncontrolled on oral therapies, sulfonylureas alone or in combination with metformin or other therapies. And they have used this IDEC-LIRA, and it has demonstrated not only efficacy but also safety compared to placebo in insulin-naive patients previously on sulfonylurea and metformin. Over to the last one, that is a Dual 5 trial. This is a head-to-head comparison of IDEC-LIRA versus one of the commonest basal insulins globally used, and that is Glargine. And this is the study design, IDEC-LIRA, metformin in one arm, and Glargine and metformin in the other arm. The results are really impressive. A robust reduction in the SpA1C, marked difference in the occurrence of confirmed hypoglycemia. We can recall the brainstorming, virulent lecture by Dr. A.K. Singh, one of my good friends. And this is how degludec is so different from the other X60 molecules. And again, a fabulous reduction in the daily dose of insulin. So in conclusion, this trial has shown IDEC-LIRA superior to insulin Glargine as a basal insulin in all the three parameters: A1C reduction, in the risk of hypoglycemia, and in reducing the weight. Over to another study that we have published, a brief discussion, and this is again on liraglutide. We published the efficacy and safety of liraglutide in 195 Indian patients with type 2 diabetes. And these were the baseline therapies where we have added IDEC-LIRA, we have added Victoza, biphasic insulin, insulin aspart, Detimer, those who are on Glargine. And across all therapies, we were able to show an average reduction in the A1C. And this is a reduction in the body weight, again very impressive. And you have an option now where you have the complementary actions of two time-tested molecules. You have GLP-1. We have been listening to the lectures earlier by Dr. Padmashri, Dr. Mohan, on the pleiotropic actions of GLP-1 analog and on the multiple actions on multiple targets by basal insulin. And when you combine together, whether you add insulin onto GLP-1 or GLP-1 onto basal insulin, these are the opportunities to enhance the efficacy and to eliminate the side effects of each of these components. And this is those therapy choices where you have the reduction in A1C, which is more with this combination, the fasting plasma glucose, and the tendency towards weight gain, which is often seen with insulin. It appears to be counterbalanced by the weight reducing effects of liraglutide. And one another reason for this weight loss could be the reduced mean insulin dosage, which is required to achieve the same A1C level in this combination. Let me briefly go through some of the cost-effective models in diabetes therapy. This is from Europe, but you have the Indian rupees over here. And these are the 5 major categories of patients. When compared to those patients not having diabetes, patients with diabetes who are on comprehensive therapies will require more resources than others. Whereas if a diabetes patient is developing microvascular complication or macrovascular complication, the cost of treating diabetes escalates by several fold. And this is 4.1 fold with the development of both micro and macrovascular complications. And this is a hypothetical model of a patient X versus patient Y. X with an A1C of 7 and Y with an A1C of 9.1. When compared, you have Mr. X living 20% longer and 60% longer without complications, and Mr. X will cost 20% less than Mr. Y. And this is the benefit, which is the proven benefit with cost-effective therapies. And soon, this is going to be a reality. Already approved in Europe, already approved in India, and I believe that this will be available within 1 year. And this is a cartoon where you have a patient who is initiated on conventional therapies for diabetes. Except during the initial few years of diabetes, the journey is full of obstacles and barriers, culminating in premature complications and death of the individual. In contrast, you have now therapies which can offer lesser chances of hypoglycemia, very low glucose variability, and very low chances of obesity. A brighter, better, and a smarter path ahead. Thank you very much for your patient hearing.
This symposium is sponsored by Novo Nordisk. I'm the medical director of Novo Nordisk India, so I have no conflict of interest here. But of course, whatever data I'm going to present is from an innovator company who always operates at the cutting edge of research, especially in the field of diabetes. And whatever data I'm going to present here are the stuff textbooks are made of, and I'm going to present some of the data from our own data on the R&D file and also from peer-reviewed journals. The title of today's lecture is Working Together, Best of Basal and Prandial Insulins, My job has been made very easy by Dr. A.K. Singh, who laid the foundation for deciphering the differences between the various basal insulin analogs, and his concluding slide mentioned which is the best basal. And that is why this title I'll be using to communicate to you on this novel molecule which is a co-formulation of the best of basal insulin analogs, namely insulin degludec, and the most widely used prandial insulin across the world, insulin aspart, and this is called IDEG asp, or the brand name is Rhizodeg. This is launched in India for the past 6 months, and I'll be taking you through these headings. I'll be briefing you on the formulation, I'll be briefing you on the pharmacokinetics and dynamics, and briefly on the clinical trial evidence, and conclude on how this best of basal and prandial insulins together can translate to patient benefit. Now, the co-formulation what we are talking of belongs to this category of insulins. So you're all familiar with premix insulins. These are the most widely used insulins in our country. So you see on the left human mixtard, which has soluble human insulin as the short-acting component. And if you look at the long-acting component, that again is human insulin, which means both the short-acting and the long-acting, the basal and the prandial component, have the same human insulin as the base. Then you fast forward to Novomix 30, which is biphasic insulin aspart, which contains the short-acting or the rapid-acting insulin analog aspart. And if you look at the basal part, it is again protaminated insulin aspart. So strictly speaking, these are not co-formulations. They are the same insulin, except protamine has been added to lend some element of protraction to the basal component. So for the first time, we were able to develop a co-formulation in which the base is different. They are distinct. For the short-acting component, we have the soluble insulin aspart, which is 30%, and you have the 70% ultra-long-acting soluble insulin degludec. I stress on the word soluble because both mixtard and Novomix 30 are suspensions. So you had to shake them before injecting. This is a solution, and so no resuspension required. This is the way it is available. It's a pre-filled pen containing 300 units of insulin in 3 ml solution. It's not a suspension. So each ml contains 100 units. And it's the same yeast strain which we use for all Novo Nordisk insulins, which is behind this recombinant DNA protein as well. So I will take you through the formulation first. I said both the soluble insulin component, the prandial component, and the basal component should stand out distinct from each other as compared to the conventional premix insulins. This is a schematic representation of the formulation. So you will see 2 colors. You will see the blue colored insulin degludec dihexamers and the orange colored insulin aspart hexamers. This is how it is there in the pen that you purchase from the pharmacist. How do I know that these exist independently in the formulation? The way to know is to perform what is called a size exclusion chromatography. So if you do a size exclusion chromatography experiment on this formulation, which contains both phenol and zinc, you will see the insulin degludec hexamers first, and then the insulin aspart hexamers next, distinctly eluting separately on the chromatograph. But does the same thing happen once you inject into the subcutaneous space? Because in the subcutaneous space, the dihexamers of insulin degludec become multihexameric depot. That is how they become ultra-long-acting insulin molecules. And the insulin aspart has to dissociate immediately into monomers. That is why it is a rapid-acting insulin. So how do I know that in the subcutaneous space, these two are going to be distinctly separate? So the way to do it is run the same size exclusion chromatography experiment with a formulation in which you exclude phenol, and then what happens? you see now the insulin degludec multihexamers and the insulin aspart monomers eluting as separate absorbance spectrum here as shown on this graph. So this is the evidence you have at a formulation level that for the first time we have a co-formulation with the prandial and the basal component distinctly separated. But still we need the clinical proof. The litmus test of this comes from what we call pharmacokinetic and pharmacodynamics. These are also known as clamp studies, as Dr. A.K. Singh showed you some graphs on. This is a primary source that will give you all the information. This was published last year, June 2014, where 22 subjects with type 1 diabetes were given insulin degludec for 5 days, and on day 6 they were given insulin degludec aspart or rhizodec in a dose of 0.6 unit per kilo. So for 5 days you give 0.42 units per kilo of insulin degludec, so that steady state is built, and on day 6 you give 0.6 units of ideg asp, which contains 0.42 units of insulin degludec and 0.28 units of insulin aspart. It is 70-30% combination. The graph which you see here is the glucose lowering ability. So on the x-axis is the time, and on the y-axis is the glucose infusion rate from this clamp study, and you see the rapid acting aspart effect there and the basal ultra long acting degludec effect distinctly separated here. This is a pharmacodynamic response of the co-formulation. How do I know that the aspart and degludec components are pharmacokinetically separated? So if you take periodic blood samples and measure the insulin aspart levels over time, you will find that the rapid acting pharmacokinetic properties of insulin aspart are preserved in this formulation at steady state. What about degludec? The ultra-long-acting pharmacokinetic properties of degludec are also preserved at steady state. So you have proof here, both pharmacodynamic and pharmacokinetic, that the two components are separately preserved in terms of their effects and serum concentrations. How does this compare to the available best of the premix analogs, BIASP 30? So this graph is taken from a different experiment where BIASP 30 was given in the same dose as rhizodec in this experiment, 0.6 unit per kilo, and this is the glucose infusion rate graph, what you see here. So what you see is a prolonged effect of the basal component here. So there is a rapid peaking of the short-acting component, but then you see a plateauing, and the other part you need to notice is the effect is getting over between 18 and 22 hours. What happens to rhizodec? This is the graph which you get, where you have the rapid component part and the basal component part of the glucose infusion rate curves distinctly separated. When they do clamp studies, researchers also estimate what is the duration of action. They define the end of action of any insulin in a clamp study by a standard level. In this study, they define it as 150 milligram per deciliter. All the subjects who took rhizodec here, you will see that the curves are all superimposing and they didn't leave the clamp level of 100 milligram per deciliter. What happens if the same subjects are given no mix 30? So you can see here that majority of the subjects, these are all subjects with type 1 diabetes, there is no endogenous insulin production, and so you will see that majority of them clamp has to be terminated and the insulin's action ends somewhere between 18 and 22 hours. This is the difference between the conventional premix insulins, which are the most widely used insulins today in India, and the newly introduced rhizodec molecule. Finally, all the curves which I showed you, all the graphs which I showed you is on once daily rhizodec. What happens if you give this molecule with an ultra long acting basal insulin twice daily? So in a pre-specified pharmacokinetic pharmacodynamic model, we introduced the values, and this is the curve what you are getting on the glucose infusion rate. So what it shows is the basal insulin component has retained the same glucose infusion rate levels as the once daily dose. Only the aspart component has come down by half. Why? Because insulin digludec aspart, we halved the dose from 0.6 unit per kilo per once daily. We split it into half, 0.3 unit in the morning and 0.3 unit in the evening. That is how it is used in therapy also. So the message from this slide is, when you dose these ultra long acting insulins, it is the dose which matters and not the frequency. So long as you maintain the total dose over the period of half-life, which is approximately 24 hours, there is not going to be any accumulation, unwanted accumulation or stacking, as you call it. So, ladies and gentlemen, this is the technology that underlies the new co-formulation of Rhizodec, and supported by the pharmacokinetic pharmacodynamic data. I have shown you the co-formulation which contains both ultra-long acting basal insulin digludec and the rapid acting insulin aspart. The separate pharmacokinetics and dynamics of basal and prandial components are preserved in Rhizodec at steady state. And finally, I have not shown you this data. We have done experiments in patients with different grades of renal and hepatic impairment, and the pharmacokinetics are not significantly affected. With this background, let us see how the formulation characteristics and the pharmacokinetic pharmacodynamic characteristics of distinct prandial and the ultra long acting basal component translate to clinical benefits. I pick on two trials in this. We have done a huge program, a phase 3 program of over 2,500 patients in the phase 3A, and I am going to pick just two trials, one from phase 3A program and one from phase 3B. The message which I am going to drive here will be, here is a formulation which can be ideally employed for intensification of insulin therapy. So if you have a patient who has failed on basal insulin therapy, this will be appropriate as a tool to intensify. If you want, instead of basal bolus therapy, so I'll be showing you a trial which compares Rhizodec twice daily versus basal bolus therapy. And then I'm going to show you this trial which actually has patients who have failed on prior premix insulin, to whom you will use Rhizodec twice daily to intensify. This was published in Diabetes Care last year. So it has two arms here. In the inclusion criteria, I have highlighted the patient profile. They were previously treated with premixed insulin. So you have on one arm Rhizodec twice daily, plus those are the oral anticoagulant drugs, oral antidiabetic drugs which were continued, and in the other arm you have Novamix 30 with the same OADs continued. It was a 26-week trial. So if you look at the baseline characteristics, this was a trial which was global. It had almost 50% of the patients, 45% of the patients came from Asian countries, including India. So that will be noticed in the BMI level, and if you look at the baseline A1C, it was matched in both the groups, both Rhizodec and Novamix 30 of 8.3. As Dr. A.K. Singh mentioned, these are all treat to target trials, but I would like to qualify that treat to target by saying that these were aggressive treat to target trials. The pre-meal glucose targets was 4 to 5 millimole per liter. 72 to 90 milligram per deciliter was the target here to which investigators had to titrate both insulins. That was the FDA requirement, which is why in all these trials you will see that there is no difference in A1C. But these are all called what we call non-inferiority trials, and so that is the primary endpoint which we proved there. But if you see the fasting plasma glucose, so for the same non-inferior A1C reduction, you find a better reduction in fasting plasma glucose, coupled with both 32% lower rate of confirmed hypoglycemia and 73% reduction in nocturnal hypoglycemia. You'll be more interested in the 9-point self-monitored plasma glucose levels. So you see that overall the 9-point SMPG profile indicated a lower glucose increment for Rhizodeg across all time points. Statistical significance was achieved at 3 time points, namely pre-breakfast, 19 minutes post-breakfast, and also the pre-breakfast next day. So weight, there was less weight gain with Rhizodeg as compared to Novamix 30, and that was statistically significant. This is an interesting slide which actually shows that for a non-inferior A1C, statistically significant reduction in fasting plasma glucose, reduction in both confirmed and nocturnal hypoglycemia. Look at the last 2 rows, the total dose. 90 units end of the trial for Rhizodeg and 98 units for Novamix 30 twice daily. That translates to an 11% statistically significant reduction in insulin dose. Putting all these things together, this is the profile, clinical profile of the molecule. If you shift a patient from premix insulin plus or minus OAD, you will find a non-inferior A1C. Don't expect an improvement in A1C, but FPG will be significantly reduced. Hypoglycemia will be reduced, nocturnal hypoglycemia reduced, and there's an 11% dose reduction. The last trial which I am going to show you, as I told you, if you have a patient who has failed on basal insulin and if you want to intensify, the golden form of insulin therapy is basal bolus, and we use the best basal that is available. So the basal bolus was insulin degludec and insulin aspart, pitted against Rhizodeg twice daily. So you have 2 to 4 injections per day of insulin aspart plus 1 injection of insulin degludec versus twice daily Rhizodeg. That was the trial here, and these were basal insulin failures. 64% of the patients were on glargine. Again, you can see that this trial was mainly Caucasian, and so in the row on BMI, you will see the Western BMI here of height of 32 here, and then once again the pre-study A1C is at 8.3 and then matched across both the groups. So again, if you look at A1C here, so there is no treatment, there is no difference in the A1C between the two, but what is noteworthy here is Rhizodeg twice daily reduced A1C by 1.3%. Basal bolus reduced by 1.5%, which is clinically relevant here. Fasting plasma glucose was equivalent to basal bolus. Confirmed and nocturnal hypoglycemia were numerically lower for Rhizodeg twice daily as compared to basal bolus. So here you have a new co-formulation which is matching basal bolus therapy. Okay, no difference in terms of A1C, no difference in terms of fasting plasma glucose, but numerically lower confirmed hypoglycemia, lesser nocturnal hypoglycemia, but then less number of injections also. Remember, you had anywhere from 3 to 5 injections in basal bolus versus 2 injections with this, and this is the 8-point self-monitored plasma glucose, which actually shows a reduction with both the molecules here, except of course during lunchtime, the basal bolus shows a lower prandial glucose increment because patients get an extra prandial insulin there, and then this benefit of course repeats here also. So you will see the end of study dose, there is a 12% reduction even in this trial. Less weight gain with the twice daily dose of with Rhizodeg as compared to basal bolus as in the previous study. And then if I see the clinical profile again across the 5 parameters in this study, so you can see that it is matching the basal bolus therapy on 4 of the 5 parameters, and in terms of dose there is a 12% reduction and also less number of injections, which is why it can be recommended as an alternative to basal bolus therapy. Finally, a word on the dosing. The start dose of Rhizodeg is always 10 units if you are giving it once daily. If you are giving it twice daily, split it into 2, 5 units and 5 units. If you are transferring from basal only or premix insulin. It's a unit-to-unit transfer. If you are transferring from a basal bolus therapy, generally it is the basal dose which is the dose of Rhizodeg with which you start. And then for titration, this is not the titration step which is in the pack insert. It is only a suggested titration schedule. You follow what is called the 202 algorithm. Fix the target. If the patient is not at target, escalate the dose by 2 units once a week, or if the patient is at target, maintain the dose. If it falls below target, then reduce the dose by 2 units. This is a simple titration schedule, and it's a very simple molecule to use. So to conclude, ladies and gentlemen, I have communicated to you that here is the world's first soluble co-formulation. It belongs to the same group, premix insulin, but chemically it's a co-formulation of an ultra-long-acting basal insulin degludec and the rapid-acting insulin aspart. The pharmacokinetics and dynamics of basal and prandial components are preserved in the steady state. So I have shown you data from steady state clamp studies as well. The first study which I showed you in diabetes care last year, insulin experienced patients, Rhizodec twice daily provides effective glucose control with lower risk of hypoglycemia versus Novomix 30. So if you have patient on Novomix 30, shifting to Rhizodec will bring additional benefits. And the last trial which I showed you makes the message that Rhizodec given twice daily offers the potential for a simple alternative to basal bolus treatment in patients who require intensification. I have not shown you studies in comparison with glargine for want of time, but we have studies which suggest that this can also be a suitable option over glargine for initiation with the largest mean. Thank you for your patient hearing. Thanks a lot, Chairman sir. We don't have pen fills. We have only pre-filled pens launched in the market. There are no pen fills available for this molecule.
Actually, usable disposable pens are becoming little costlier. When the cartridges will come, it can be inserted in pens and price will come down, I think. Any other question to Dr. Singh?
Sir, to answer your question, what I have learned is when you use insulin in a larger scale and when the manufacturers globally feel that there is a huge number using a particular insulin in one country, then they will start developing cartridges for that country. So they are waiting for that situation to occur in India. In some other areas in the world, cartridges for Rhizodec is already available.
I want to ask Dr. AK, is there a comparative study between glargine and detrimer? That is number one. And the other two, we take Rhizodec twice a day only. But then we take 3 times food at least. So one of those might produce a postprandial surge. So on the long run, would there be a higher incidence of endothelial dysfunction in people taking Rhizodec? Because one meal is not covered.
Yeah, so the first question is there any study head-to-head between glargine and detimir? There are. Actually, I shown you on the slide, which you could not see. There are several head-to-head study of glargine versus detimir, which actually suggested no difference in terms of HbA1c. Actually, it was a treat-to-target trial, so you don't expect any difference in HbA1c reduction. But to achieve the same HbA1c reduction, you had a lesser nocturnal hypoglycemia in detimir arm compared to glargine. But the biggest drawback with the detimir was the dose requirement. The dose requirement was almost double, or at least 1.5 times of glargine. So, if you look pharmacologically, detimir is even an improvised version over the glargine because of their albumin attachment. But there was less weight gain also with the detimir compared to the glargine. So in 2 parameters, detimir were superior to glargine in spite of achieving the same HbA1c. The one was even a better nocturnal hypoglycemia reduction, and another was the weight gain with the detimir. But the biggest drawback with the detimir was the dose requirement. And that is why detimir is not become so popular basal insulin, because of twice daily injections, higher dose requirement. But if you compare again in terms of weight gain and hypoglycemia, it is better than glargine. Okay, so yeah, I mean, this is a very popular question asked every time, that why one should use Ryzodeg twice daily. Because you are using a degludec insulin which has got a once daily half-life, which has got a half-life of 25 hours. Then what is the point of using twice daily degludec in a Ryzodeg preparation? It's a very question often asked in every meeting. The point is, the beauty, if you closely look into pharmacology, it's a science of pharmacology, it's science of pharmacokinetics. When you give a longer acting insulin twice daily, there is no stacking. That's the beauty. In any pharmacological agent which actually follow the first order kinetics, the rule is, if the longer acting it is, even if you give the twice daily injection, it should not cause stacking. Unlike the shorter acting insulin, if you inject it frequently, it will cause more stacking. So theoretically, one can argue that why to give a twice daily insulin, like degludec, which is such a longer acting. But remember, when you are giving a twice daily injection, you are dividing the dose into two parts. If let's say somebody is getting 20 units of Tresiba, if you want to put him into Ryzodeg, you are dividing into two parts, as a 10 unit in the morning and 10 unit in the evening. At the end of the day, the total dose requirement remains same as you are giving as a once daily or a twice daily. But what advantage you are getting, that you can add a 2 prandial bolus in the same pen. Otherwise you would have a different 2 pen, one for a SPART or one for maybe for Lyspro or whatever, whatever you use, even Ectrapid, whatever you use. But here you have got a combination of a SPART and degludec in a single pen combination. You can inject it twice daily, you are getting 2 bolus dose, but you are not getting the stacking, side effect of the longer acting insulin. That's the answer.
Dr. A.K. Singh, the question was, it's okay, if you give twice daily Ryzodeg, what will you do for the lunchtime prandial surge? That's
right. Well, so yes, if your patient are on twice daily Ryzodeg, and if you are not getting true control in terms of post-lunch hyperglycemia, you need to add another bolus insulin before the lunch. There is no answer for that, because the SPART remains the SPART. It will work during the breakfast time. It might not go up to the level of to cover of lunch prandial rise. So you need additional bolus dose prior to the lunch, or you can add any other drug. Let's say alpha glucosidase inhibitor or a DPP4 inhibitor, which has got a PP reducing potential.
But again, sir, it depends on in what stage of diabetes you have initiated insulin. If you are initiating insulin sufficiently early in the natural history of diabetes, then the patient may require only once or twice of Ryzodeg daily. And the post-meals will be very high when the evidence is very high in advanced late stages of diabetes, when probably you require more frequent dosages. So if you initiate early, then Ryzodeg is aimed at the postprandial, which is the maximum for that patient. So you assess the largest postprandial excursion is to be addressed with a dose of Ryzodeg. And that need not be breakfast or dinner, that can be lunch or dinner, or it can be breakfast or lunch. And many a time you may require only one shot per day. And always remember that we are going to combine insulins with oral therapies. And the oral therapies are also going to address the so-called postprandial excursions.
But in majority of cases, from our long experience, we are using 30-70 preparation, 2/3 in the morning and 1/3 in the evening before dinner. And in those cases only you heard Dr.Awadhesh has told that for post-lunch is still high, then you can use one preprandial short-acting or acarbose group of drugs. Any other question to Dr. Jothydev or Awadhesh or Dr. Srishyla? So we should declare the session to be closed. Let us give big hands for the speakers and also my co-chairperson, Dr.Banshi Saboo. Thank you.
Thank you all. I request Dr. Vasudevan Poti, Additional Professor, Department of Urology, Medical College, Trivandrum, to hand over the memento to Dr. Samar Banerjee and Dr. Awadhesh Kumar Singh. And I also request Dr. M.S. Zulfikar Ahmad, Senior Consultant Neurosurgery, SUT Royal Hospital, Trivandrum, to hand over the memento to Dr. Jothydev Kesavadev and Dr.M.V. Srishyla.